Dr. Dino Patijala, Excellencies, ladies and gentlemen. Thank you very much for having me. I remember speaking about the need for stronger international cooperation against COVID-19 at this global town hall last year. Since then, something have changed, but some have not. We now have a powerful weapon to defeat COVID-19. 24 COVID-19 vaccines have been approved for use, and around 7.6 billion shots have been administered globally. And see the result? The result is apparent. Global economy is showing signs of life and is projected to grow 5.9% in 2021 and 4.9% in 2022. Borders are reopening and international travel has gradually resumed. In-person meetings have begun to take place, including recent G20 and some COP meeting. Images of crowded football stadiums and concerts give us hope that life will soon return to normal. However, let us be clear, we are still in the pandemic. We have recorded nearly 260 million cases globally and 5.2 million deaths due to COVID-19. These figures are 4 to 5 times higher than they were a year ago. The WHO noted an increasing trend in global weekly cases in surge in the Americas and Europe. A number of factors contribute to prolonging the pandemic, such as inconsistent public health measures and hasty reopening. But the WHO make it clear that the pandemic persists in large part because inequitable access to tools persists. Excellencies, ladies and gentlemen, from the very beginning, Indonesia has called for fair and equitable distribution of vaccine. My president has voiced his concern in bilateral, regional, and multilateral forums. I also co-chair COVAX AMC engagement group, established to facilitate access to vaccine for 92 countries. We knew vaccine would be scarce, and scarce goods are often sold to the highest bidder only. And this is exactly what is happening right now. 64.99% of people in high-income countries have been vaccinated with at least one dose, compared to 6.48% in low-income countries. More than 80% of vaccine have gone to G20 countries, compared to 0.4% to low-income countries. Every day, there are 6 times more boosters administered globally than primary doses in low-income countries. 56 countries did not meet the WHO target to vaccinate 10% of their population by September 2021. And nearly 80 countries may not reach 40% vaccination target by this year end. All the while, at least 100 million doses could go unused and expire in G7 countries in 2021, and the number of wasted doses could rise to 800 million by mid-2022. If all the shots administered globally so far were distributed equitably, we would have reached our 40% target in every country by now. Instead, many countries rely on COVAX facility as the only means to get vaccines. COVAX has shipped over 507 million doses, but COVAX does not produce vaccine, and it has already fallen short of its target to deliver 2 billion doses this year. We still need 550 million shots to meet the WHO 40% vaccination target in every country. Global production now stands at nearly 1.5 billion doses per month, So there is actually sufficient vaccine from a supply perspective. But will they be distributed equitably this time around? Colleagues, ladies and gentlemen, challenges to vaccinate the world do not stop here. We must get the shots into as many arms as possible, and this is no simple task. There are misinformation and hoax to counter as they contribute to vaccine hesitancy. Not all countries are prepared to receive big number of doses, let alone have a national strategy to distribute them. On average, low-income countries have to increase their health spending by 56.6% to cover costs of vaccinating 70% of their population, compared to 0.8% for high-income countries. We also have to consider the issue of vaccine discrimination. Some countries are denying entry to people with vaccine that has the WHO emergency use listing, but has not been approved by their own regulators. Colleagues, ladies and gentlemen, in the short run, I have a few suggestions to make. First, ensure all countries meet the WHO vaccination target. This requires commitment to equity. All pledges of dose sharing must be fulfilled immediately. Wealthier countries with an oversupply of doses or with high vaccination coverage should consider sharing their doses. Vaccine manufacturers also need to start allocating more doses to COVAX. Second, scale up global vaccine production. Diversification of vaccine manufacturing to developing countries would contribute to such effort. This requires strengthening of necessary infrastructures, research center, storage facilities, and human resources. Export restriction on raw material must end. Technology transfer should be facilitated. Third, strengthen the absorption capacity of developing countries. Many require assistance to accelerate the pace of vaccination. International financial institutions may provide much needed financing. At the same time, engagement with WHO country office must be intensified to design effective vaccination strategy. Then look at what should we do in the longer run. In the longer run, we must build on our experience in dealing with COVID-19. And two big priorities for us now. First, build a stronger national health infrastructure. This means investing in resilient healthcare system and making it more affordable for everyone. This also means strengthening our health industries, scale up their production and distribution capacity. International cooperation in vaccine research and development must be intensified, including with Gavi and CEPI. Second, strengthen global health governance. Colleagues, the WHO is only as strong as we make it to be. Its role and legitimacy remain irreplaceable in coordinating global health action. The discussion on the new pandemic treaty will soon begin, and I hope all countries could rally behind this initiative. We also need a new health financing mechanism for developing and least developed countries. G20 has taken up this issue, and modalities for such mechanism is now being deliberated. And lastly, we need a permanent mechanism to improve equitable access to medical solutions. And going forward, SCTA, including COVAX, could be adjusted for such purposes. Excellencies, ladies and gentlemen, now is the time for action. I repeat, now is the time for action. We have enough tools at our disposal to end this pandemic, including vaccine. But tools are just tools if not used properly. And to make them work, we need solidarity. We need political commitment from all countries. Once again, from all countries. Only then can we recover together and recover stronger from this pandemic. I thank you very much.
Thank you, Minister Marsudi. Ladies and gentlemen, to begin the session, may I invite the moderator of this session, Professor Chandra Yoga Aditama, the member of COVAX Independent Allocation of Vaccines Group. Professor Aditama, the floor is yours.
Thank you. Excellencies, distinguished colleagues, ladies and gentlemen, good morning, good afternoon, and good evening. So thank you for joining this session 6 of the Global Town Hall. We will discuss about the COVID-19 pandemic in the year 2, the challenge of vaccinating the global population. To discuss this important topic, we are very honored, we are very fortunate to have 4 distinguished, eminent panel members with us. We have His Excellency Khairi Jamaluddin. He is the Minister of Health of Malaysia, and Minister Khairi leads Malaysia efforts to bring down the COVID-19 cases. Good afternoon, Minister Khairi. And we also have Professor Yuzfo Gao. Professor Gao is the Director General of Chinese Center for Disease Control and Prevention, so the Director General of Chinese CDC. And Professor Gao leads China's effort to defeat the COVID-19 virus in his role as the DG of CDC. So good afternoon or even good evening, Professor Gao. And we have Dr. Alakija. Dr. Alakija is the co-chair of the African Vaccine Delivery Alliance, APDA. And Dr. Alakija is a strong advocate of vaccine equality in underdeveloped countries, especially in Africa region. Good morning, Dr. Alakija. I'm sure this is still morning in Abuja, Nigeria. And from WHO, we have Dr. Bruce Aylward. He is the Senior Advisor to the Director General of WHO and head of the Access to COVID-19 Tools Accelerator Hub, ACT-A. And Dr. Aylward leads an international multi-agency effort for equal access to COVID-19 tools. Good morning, Dr. Aylward. I'm sure Geneva is also now in morning. Without further ado, let us begin our discussion. If I may begin with His Excellency, Minister Khairi Jamaluddin. So, Minister Khairi, as we know, as also mentioned by Her Excellency Minister of Foreign Affairs of Indonesia, we can say in general that for this COVID, no one is safe until everyone is safe. So, in this regard, Minister Khairi, what is your view? Do you believe that the target of vaccinating the whole world, it is a realistic goal that we have to achieve? And do you think that the challenges of vaccinating the world has a kind of political or geopolitical dimension to it? Minister Khairi, over to you.
Thank you, Professor, and thank you everyone for joining the Global Town Hall this evening, this morning. Should we vaccinate the whole world? Yes, we should. Is it a realistic goal? No, it's not very realistic at this present time. I think Ibu Retno has made a very impassioned speech, and she has summarized the global vaccine inequity, which to me is the greatest moral failing of the global pandemic response. How do we justify the fact that the vaccine distribution has been so inequitable when there are vaccines, when there is enough production, when we can actually get vaccines to countries who have not even vaccinated 10% of their population, and where this is literally a life and death situation. We have a production deficit, in a sense that that technology transfer is not happening fast enough. There is enough production, but in the wrong place, not in the right places. There's a distribution deficit, and this has been seen where we cannot get the vaccines in time to countries, and we've even had a situation now where developed countries have had vaccines expire. Many doses expire when they could be sent to countries who have not even started their vaccination in earnest. And unfortunately, we have a cooperation deficit. Yes, COVAX was set up with great intention. Malaysia is part of COVAX. We subscribe to COVAX. We support COVAX. But if we had relied on COVAX alone, we'd be in trouble. So, for Malaysia, very early on, we saw that, there is geopolitics to this. There is a deficit in terms of production, in terms of distribution, in terms of cooperation. And we had no choice. And like many other developing countries, we had to go for a basket of portfolio of vaccines. We bought some from COVAX, we bought some from Pfizer, we bought some from AstraZeneca, we bought some from Sinovac. And that's why we have 76% of our population fully vaccinated now. 95% of adults in Malaysia have been fully vaccinated. And I would have liked to have done that via COVAX or via a global solidarity movement. Unfortunately, I was forced to do that. We were forced to do that unilaterally. But of course, we had a lot of help. We had donations and contributions from China, from the United States, from the UK. But there was a small portion of our portfolio. And that's, my sympathies go to countries who have not even crossed the 10% mark. So it is certainly a target that we should aspire to. Is it realistic based on what we've seen? No, it isn't.
So thank you, Minister Terry. I like the terminology that you use, basket portfolio. So you compile from different sources to be able to vaccinate more than 75% of the Malaysian population. So thank you for that one. Director of China. So, Professor Gao, we all know vaccines. As vaccine manufacturers, how does China, especially the China CDC, contribute to this big effort or mega effort of global task of vaccinating the whole world? Professor Gao.
Okay, it's a great pleasure for me to be here to share, some of my opinions about, all these issues. So the question is very clear, and I think the answer from me, as you said, we have developed, or we have been developing so many vaccines. I call this in China because the political will, because of the hard working for both public health sectors and also entrepreneurs, working in the manufacturing field for the health products. I call it in China, we have a saturated R&D, saturated. So we have enough platforms for all these, or facilities for the production of the vaccines. Even from the very beginning, we got it ready because of political will and hard working. Like our President Xi Jinping, he addressed in the opening ceremony of the World Health Assembly, he readdressed vaccines, COVID-19 vaccine we developed. It's an international or global public health goods. It's global goods. So that's very important. This is why China is always ready to share with everybody. So our president also readdressed the 13th BRICS summit, and we committed ourselves to donate 100 million doses of the vaccine to the world, and also $100 million for COVAX. So in general, so our political will is there. Our products are there. I think we are working very, very hard. So first, in China itself, we already, vaccinated almost, like I said, over 85% of the population now. You are talking about 1 billion people. already we have this, two doses or three doses, because we have one vaccine, it's a protein supplement vaccine. You need, three jabs. So in general, in China, we have inactivated vaccines, we have protein supplement vaccines, we have adenovirus 5 based vaccines, 3 already in the clinical use. The inactivated vaccines, we already, being used in many other countries. And the protein vaccine also used in Uzbekistan, Indonesia, so many countries there. So in general, that's our commitment and our practice. In terms of the role, China CDC is playing. We are doing a very good job. We are working very hard. We already have for the 8th prevention and control of COVID-19, 8th edition of this protocol guidelines. So we are also for the vaccinations. We already have the 2 versions of this vaccination protocols in China. Meanwhile, we also send along the mainland China to go some countries to do some clinical works, and also to guide some of the vaccination programs in other countries, including some countries in the Middle East and in South America, and also in Asia. So this is what we are doing. In general, we commit ourselves to share the vaccines, to share the guidelines, to share the techniques. At the moment, myself, I try to work very hard to encourage for the technological transfer.
Mr. Gao? Sorry, is it me only or?
The virus will share the world. Thank you. That's my comment.
Thank you, Professor Gao. Thank you so much. So I just, if I could quote one word that you mentioned, even the President mentioned that vaccine is a global public health good. So that is one big step that we for our discussion. Now, let us go to colleagues, Dr. Alakija from Africa. If people are talking about this inequity or uneven distribution of COVID vaccine, Africa is always mentioned. So if we could get, real hand experience, so as we enter the second year of the COVID-19 pandemic, how much a problem of this so-called vaccine nationalism, given the fact that we all know that the vaccination rate in African countries is relatively low compared to other parts of the world. Dr. Alakija.
Thank you very much. And it is just an absolute pleasure and an honor to be here with all colleagues here today. It's not just that we're talking about a potential vaccine nationalism. What we have is the bizarre situation where we have turned a pandemic caused by a microbe into a geopolitical crisis. The vaccine nationalism that we are seeing and that we're experiencing on the African continent and also other parts of the world. I was introduced as also agitating for vaccine equity, but equity for all tools, diagnostics and therapeutics across the entire world. To give you today's figures, as of today, 55.5 million people in the whole of Africa, 1.3 billion population have been vaccinated. 55.5 million of 1.3 billion. The numbers speak for themselves. I'm sitting in Abuja, Nigeria, where only about 9 million people of a population of 210 million have been vaccinated. That tells you that we're vaccinating less than 2%. So clearly vaccine nationalism has played a huge part in this. We all say no one will be safe until we're all safe. It was brilliant, the keynote address by the Minister of Foreign Affairs of Indonesia. And I have to say, I'm delighted to see that the G20 is going to be in some incredibly safe hands next year, and really happy to see that. And also, of course, in the hands of a woman, to see a woman as minister. So I want to give a shout out to that, because clearly the points she made were very, very clear. And she was brilliant in her analysis that we will need to address this across the entire world in an equitable manner. Let me quote some of the figures that I heard her say with regard to what health workforce. We need to look at what is happening with health workforce, for instance, across the world. This pandemic is affecting people in Africa the same as it is affecting people in Europe or in Asia. The problem is here in Africa, we have no diagnostics. We have very limited diagnostics. In the whole of Nigeria, we have tests, conducted 3 million tests in the entire duration of this pandemic. So how on earth are we going to know to vaccinate people? But we have the rich countries of the world, largely, the UK and many of the other countries of the world that are hoarding vaccines. Canada, I mean, I don't want to get into a geopolitical situation here, but yesterday we learned that over 1 million doses had expired already in Canada, 1 million. And yet the media, when they question us in Africa, will say, how do we know we should give you vaccine? Because how do we know you will not waste it? It is not for the world to say to us whether we will waste it or whether it will waste or not. We have enough vaccines across the world. It is nationalism, it is greed, it is hoarding, and quite frankly, it is a disregard for human life on certain parts of continents of the world that we see that is causing this. We need geopolitical solutions. We call for a greater cooperation, global solidarity. That's another thing that the Minister of Foreign Affairs said that I love. But I say that COVID is where global solidarity went to die. How do we come back to this global solidarity? We also call for this global pandemic treaty, but we need it to be more inclusive in its design, and we need it to be more inclusive in its governance. It cannot be governed and ruled by a few people in one part of the world who are the so-called global health leaders. It needs all of our voices, because as we, in the pre-talk, as Professor Gao said very eloquently, we are one family. And until we start acting as one family, this pandemic will not be over. Vaccine nationalism needs to change and become vaccine globalism. Thank you.
Thank you so much, Dr. Alkija. So the vaccine globalism is a very strong word from you, from the country that you said less than 2% of vaccine coverage. Thank you, Dr. Alkija. So now let's go to WHO. Of course, we heard Dr. Tedros, Director General of WHO, keep mentioning regarding that vaccines should be for every country who are needed globally, and WHO already making a target, as already mentioned by Her Excellency, the Foreign Minister, that 40% of every country should be vaccinated by the end of this year, and 70% should be vaccinated by the mid of 2022. But just now, we just heard Dr. Alkija mentioned less than 2% in Nigeria. So, Dr. Edward, from the WHO standpoint, what is the state multilateral pandemic cooperation, particularly for even vaccine distribution to the whole world population? Dr. Edward.
Thank you very much, Prof, and thank you for an opportunity to be part of this. So what's the state of vaccine multilateralism? Dreadful. Let's be completely honest. We're in a dreadful situation. The world has made over 8 billion doses of vaccine. 2 times as much of that has gone to high and upper middle income countries than low and low middle income countries. It's not fair. And it's not smart. As a result of this behavior, the pandemic will go on longer, at least 1 year longer than it should have. People will be dying for a year longer than they should have. Healthcare workers will be getting sick, and economies will be dragged. We have to be super clear. Multilateralism, when it comes to vaccines, is not working the way it should. And to give another statistic, we've had a lot today. We set a very simple goal, 10% coverage in every country of the world by the end of September. 50 countries missed that target. The simple target of 10%, it is completely due to supply problems. We have another target, 40% by the end of December. 80 countries are not on track, again, because of supply. There's a small number of fragile, vulnerable, conflict-affected countries that are going to have a challenge hitting those targets for reasons related to systems. But for the rest, it is a supply-side problem, as simple as that. because rich countries, producing countries are controlling supply. So the status of multilateralism, we cannot pretend is anything better than dreadful right now. And it did not have to be, Prof. As Minister Kyrie put it out so well and eloquently at the beginning of this, to avoid this problem, we created COVAX. We created and agreed on an international allocation mechanism. We created targets to help guide us. We pooled procurement, everything possible to be successful. And COVAX has been incredibly successful. Every dose goes out in a minute. 80% of the doses used in low-income countries are coming from COVAX. But like the minister said at the beginning in her fantastic remarks, COVAX doesn't make vaccines. The world has got to cooperate. That's multilateralism. It isn't working. And last comment, we have to be very careful if we think donations solve the problem. Donations keep control in the hands of the producers, in the hands of the donating countries. The countries, as Prof. Yodi put out so eloquently, have got to be able to control their own supply, because what's happening now, a stopgap measure, donations help solve the problem in the short term, and we're incredibly grateful for those, fantastic. But we're getting short expiry dates, unpredictable supply, and we don't control supply, which means it keeps stopping and starting. So the lowest income countries with the weakest systems are being given the hardest challenges to be able to effectively use vaccines. This is not fair. It's not just. And as a result, people are dying that shouldn't die. We can't pretend they aren't. Healthcare workers are getting sick that shouldn't. We can't pretend that's not happening. And the world's economy is in a drag. High-income countries, middle-income countries are taking a hit as a result. We can't pretend it's different. Simple solution. Get out of the way, let COVAX buy the vaccines as contracted. We have a market failure here. We have contracted, $10 billion worth of vaccine. We're not getting it. But what we are getting is donations of the same vaccines that are going to other countries who say they can't use it. This is a perverse situation. Multilateralism is not working right now when it comes to the equitable distribution of vaccines. And to the minister's earliest point, my last one, I promise, it was realistic to hit 40% of the world's population by September. We had enough vaccine. We'll have enough vaccine to vaccinate 70% of the population in every country of the world by the end of February. We won't hit those targets because we're not sharing the vaccines equitably.
Oh, thank you, Dr. Edward. So it is clearly stated that 80 countries in the world. So 80 is, I think WHO member state now is less than 200. So 80 countries out of 200 will not achieve target of 40% by the end of this.
Half the world.
So that is the real challenge that we can discuss furthermore in our meeting. Thank you, Dr. Awad. If I may go back to His Excellency Minister Kyrie, there is another issue not really another issue, but there is another part of this challenge of vaccinated people in the country. That is the vaccine hesitancy. If I'm not mistaken, on 2019, even before COVID, WHO already mentioned the 10 global health threat, and one of the 10 global health threat on 2019, even before COVID, was vaccine hesitancy. So that means for other type of vaccine. But now we're also seeing this vaccine hesitancy for COVID. So how do you deal with this vaccine hesitancy issue in Malaysia? So if you could share with us, Excellency, maybe other, could get the benefit of your experience. Minister.
Thank you. Just before I answer that question, I just wanted to follow up with 2 points on the earlier discussion. One, I think the point was made earlier about vaccines being given to countries, and then people saying, well, you don't have the capacity, so you don't need that much vaccines. I think that's highly condescending, and I think that is a huge part of why some countries are not getting vaccinated. I remember when I was negotiating with pharmaceutical company X earlier this year, and I said, I need this amount for the third quarter of this year. And I said, are you sure you can absorb this amount of vaccines? And just to prove them wrong, when it arrived, I made sure that Malaysia's daily vaccination rate per capita was the highest in the world compared to the peak of what the UK and the US was, just to prove a point. The second thing is, I'm starting to see the same inequity now when we are negotiating for children's vaccines. I've had an indication of the delivery schedule for the children's vaccines that has just been approved by the FDA. And it's the same thing again. We're going through the same round of inequity again. Most of the vaccines that will come to Malaysia, even though we are one of the earliest to put down, who are willing to sign an agreement, is going to come towards the end of the second quarter when other countries have started vaccination. So, I mean, unless we really look at this and talk about globalism, multilateralism, we're going to repeat this all over again next year with therapeutics as well. But coming back to the point of hesitancy, I'm happy to report that in Malaysia, 98% of our adult population have received at least one dose. I think the first thing is transparency in data and trust. We line list every single COVID case every day on GitHub, which is a global data repository. It's anonymized, of course. So every single detail about every single COVID case, death, what type vaccine they took, when they were vaccinated, it's all there. I think we have one of the richest data, open data that's available, and we communicate this not just in the repository, which is very, very high, very, very detailed, but we have a snapshot website which we update every day on how effective the vaccines are. And that communication has to continue, and I think a large part due to the fact that once our vaccination rate got past 40-50%, death rates started dropping, and hesitancy, of course, dropped as well. But the other thing is, you have to go toe-to-toe with the anti-vaxxers. I mean, some people say just ignore them. But I think in the spirit of openness and transparency, I gave them the first right of reply. I went onto their Facebook pages and I spoke. And of course, there comes a point where you stop engaging with people who are just sometimes, they're just irrational. But I think you have to demonstrate to the people, the fence sitters, that you're willing to go toe-to-toe, tell them what the science is, what the facts are, and pretty much let the naysayers, the anti-vaxxers, embarrass themselves. And of course, we have apart from carrots of being vaccinated, we have stick as well. We've said for anti-vaxxers that, or people who refuse to get vaccinated rather than cannot be vaccinated on health grounds, that you cannot do certain things. You cannot go to restaurants, you cannot go to shopping centers. If you go to a public institution and you refuse to be vaccinated, you have to do regular tests, which you have to pay for. So I think we have embraced openness, transparency, data, willing to engage with people, but there has to be some stick, as it were, that really tells people, you should be vaccinated. If you don't, then there will be freedoms that will be denied to you.
So thank you, Minister. So as you said, it has to be both. I mean, transparency should be there, openness should be there, trust should be there. But on the other hand, carrot and stick approach should also be implemented. So thank you for a very, very important experience that you share with us. If I may go to Dr. Alakija again, I mean, you clearly mentioned the less than 2% for Nigeria, and for Africa, it's 55 million for the whole African region. And then we already talked about the global solidarity, how can we support from globally, and Dr. Alvar mentioned about multilateralism is not really working in this regard. So how do you think that we should achieve vaccine equity in Africa? I mean, besides global, is there any regional solution for this very important topic to be handled? Dr. Alakija.
Thank you, Prof. First of all, let me speak to what Minister Carey just said, just as he spoke about negotiating for children's vaccines. Oh, the luxury. The luxury to be able to say that one is negotiating for children's vaccines. That is so far from our reality here in Africa that it just makes me want to cry. And that in itself, that we can have that juxtaposition that the minister from Malaysia is able to be negotiating for children's vaccines, and yet here we in Africa are still begging and pleading for the world to not to allow it to buy vaccines, but to release the supply necessary for us to get in place in the queue. You ask whether a regional approach will work. We have a failure of the global system. You know, we have a failure of global health infrastructure. We have a failure of global multilateralism in this moment. The last time we had such a failure was I think, during the world wars and sort of 70, 80 years ago in the world. And yet it appears we have not learned from those mistakes. Africa has 55 member states, but these are also sovereign states. You know, that 55 million vaccinated of 1.3 billion is 0.55% of the population of the continent. We used to talk about achieving herd immunity. That was before we truly understood this thing. You know, and I think we're all learning as we go along. I mean, I'm every day we're waking up and learning more and more and realizing that herd immunity is not really a goal anymore. We have to really, as Professor George Gao said, we need to be going really for zero COVID, but for many of us that is now impossible. Multilateralism, therefore, should have been the answer. It should have been multilateralism, COVAX and other multilateral mechanisms, the ACT accelerator, because we're not just talking about vaccines. We're also talking about people dying for lack of breath, people dying for lack of oxygen. We're talking about people dying for lack of diagnostics, because when these new antiretroviral treatments come into play, we're told that they're only effective when they're given within 4 to 5 days in early diagnosis. If you don't have testing, you can't do early diagnosis. So as a region, Africa region, we looked to multilateralism, we looked to COVAX, we looked to the world and to ourselves and to bilateral arrangements to try and save our people, literally, as Bruce said, save lives. But we've had to go to regional cooperation and regional regional coordination. Now, this regional coordination is difficult because, of course, you have sovereign states. You have Nigeria, you have Senegal, you have South Africa, you have Egypt, you have Tunisia. I mean, Africa is a behemoth. Africa is not a country, as we say. So regional cooperation and collaboration and coordination has come as a result of a failure of the health system, you know, because it has happened because the established world order that is underpinned by power structures that are holding continents like Africa in stasis has not considered the needs of those who are living in the parts of the world where people are being left behind. We're talking about working towards, you know, the global goals, but we're seeing what COVID is doing is rolling back all of those gains. So they say that if you reach out your hand for help and nobody will help you, you must begin to try to help yourself. We have tried bilaterally within Africa. Countries have tried to purchase vaccines and negotiate, as Minister Carey said, and have been rebuffed because of greed, because booster doses were being purchased by the global north, because, you know, it was thought that we were told that you, as he said, also you can't absorb those doses, but we have healthcare workers who are dying. And as Bruce said, the other thing that our regional cooperation and collaboration is showing us is that we are losing our health workforce. We are losing those who should have been vaccinated at the beginning when we were trying to achieve 10%. They're all dying. So as a region, we're trying to come together to rebuild our health workforce, to rebuild our systems, to rebuild our procurement and get greater bargaining and negotiating power as a bloc. I would say that it is a system in progress. I would like to see it stronger. Africa Union does not operate necessarily as a bloc, and I would like to see our political leadership, and now I speak to African political leadership, that we need to be stronger in our voice. How is it that the G20 really doesn't really include Africa per se? How is it that G20 nations do not include Nigeria? We need a G20 plus that includes more of Africa, that includes more of that voice, that includes more of Nigeria, because it is global cooperation that we need. It is global solidarity. We can't have an Africa pandemic treaty and not a global pandemic treaty, because viruses and threats know no borders. The health security of China, the health security of Africa is the same as the health security of Europe or the health security of America. We have to stop believing that anyone can go it alone. Thank you.
Thank you, Dr. Akija. So you mentioned about the failure of global health system, and you also mentioned about there was also, besides vaccine nationalism, there was also a discussion about ventilator nationalism, or maybe oxygen nationalism, or even antiviral nationalism later on. Anyway, so that is our challenges that we have to tackle. So Dr. Gao, Dr. Alakija just mentioned about booster, and I think others also talking about booster. That's one hand. But on the other hand, we know scientifically that the efficacy of vaccine will decrease over time. So we know all of that. But so some country already begin this booster, and some said might be good, might be not good. Why not give them to other country who are not receive vaccine? But what do you think about vaccine booster? I mean, scientifically, how do we stand off this vaccine booster? Do we really need it? Do we have to give it now? What is your view in this regard, Professor Gam? Over to you.
Okay, let me just address a little bit more about Dr. Alakija's saying just now. Global multilateralism, I think I would like to support this. This is very important. For the vaccinations and for the pandemic, they are not bilateral, nothing bilateral. We got to make sure, it's not just understanding, it's the implementation. All the measures must be there for the multilateralism. So that's one comment. And for your question, scientifically, this is a new virus. This is the first time for the human being to encounter with a coronavirus pandemic. We never have a coronavirus in the history record. So obviously, by now we know it's very similar to the influenza virus, very similar to other respiratory infectious diseases. You have some antibodies in your blood. You have some high titers. Maybe it doesn't work because it's a respiratory infection. There's no viremia, clear viremia there. So the antibody wouldn't work. And secondly, even you have antibodies and the body is still there, but the problem is the decline or waning of the antibody is already there. Either it's a model mRNA or I use a traditional, blanket. It's not really traditional. Like Tokyo vaccine, it's not traditional. It's also high tech, but compared with mRNA, it's traditional. Inactivated mRNA, adenovirus-based or any influenza virus-based vaccine, I call that one traditional because compared with mRNA. But they are all social, and the antibodies are declining. So that's the science. It's not a technology. It's not common sense. It's a science. Because the human beings, we know. So we have antibody, the antibody is declining. So in general, we need a booster jab. I think it's clear. Either model mRNA or so-called traditional or canonical is a better word, canonical vaccines. So we need booster jab. I think that's already the common agreement with everybody in the field. And this is why in China, let me check the number. In China, we already have we have started our booster jab in October. 1 month ago, we already started for some special, some of the special career populations, high risk. For example, the high risk populations. We already have by November 18th. Is the number I got. Approximately about 80% of the high-risk people already been booster vaccinated. So in general, we need this. China already initiated this program. And lastly, I want to say, we need to think about scientifically. We have so many choices already. So we are thinking about sequential, heterologous sequential vaccination. You might, by using one vaccine to prime, and then using the second other heterologous vaccine to do the booster jab. So this is something, it's still science. We still need to collect more data to say whether or not it will work. But basically, by immunology, by the science, it will work. That's something we should think about it. Thank you.
Thank you, Sir Professor Go. So by science, by immunology, it will work. So now let's move again to WHO. Dr. Elwad, we already discussed about vaccine in general and even distribution and even booster. So, but the issue is not only vaccine for COVID, of course. One of the main discussion is about the new variant, about Delta or AY4.2 or whatever. So with the current and upcoming COVID-19 new variants, how will this affect the global effort in alleviating the pandemic? Or in general, what are the new challenges, I mean, besides vaccine, besides new variants, that the state or countries have to face in the coming time. I mean, say it in the coming year for our effort to taking COVID-19 in the world. Dr. Elwin.
Thank you, Prof. The variants, as everyone on this call will be aware, have important implications for the battle against COVID. Because what's happening is they are introducing a new degree of uncertainty in this battle. What we do know, and they're showing already, is the virus evolves. What we don't know is will it evolve to a point of immunologic escape, which means our vaccines don't work anymore and we need new vaccines. This is a real possibility, and it has big implications for how we work. Now, it presents new challenges, but we can manage those challenges. George, you put it so well, right? We can manage these challenges because we have vaccines now, we have the technology, we have other things. What's the challenge, Prof, is going to be our behavior. How do we use those tools? How do we evolve those tools? Because our behaviors are failing. And Yodi put it so well, just then the minister, in terms of equitable distribution. So what do we need to do as a result of the variants? First thing, optimize the use of the tools we have, which means vaccinate the right people in the right places at the right time to get as good a control as possible. Because the more we control this virus, the less variant emergence. So that's the first thing. The virus is telling us, equitably distribute and use these vaccines, you fools. Don't use them the way you're doing it today. So that's the first thing. The second thing we've got to do is enhance our surveillance. We have inequitable vaccines that everybody talks about, but we have an even worse problem. We have inequitable use and access to diagnostics. And that means we can't see this virus emerging. So we have to have a huge step change in our testing rates and our sequencing. Every country should be able to do this and do it at high rates. We have less than 10 tests per 100,000 population in countries like where Yodi is calling from. But in other parts, like where George is calling from, we are over 100. Where I'm sitting, they're in the hundreds. So the testing rates are all wrong. And as we test, Prof, we've got to make sure, because we need to incentivize that there's equitable access to these exciting new antivirals that are coming out, because that will help incentivize people to get it tested. But if they can't access the antivirals, that ain't going to happen, and we're not going to have the biggest impact. So we have to do that. The other big thing we've got to do is maintain our research agenda, right? Everyone thinks, okay, we have the vaccines, we have the solutions. You got to maintain the R&D, you got to maintain the surveillance, you got to maintain the operation, got to continue to invest in the CEPIs and the other great organizations that help make sure that that work happens. And then to the point, I think Minister Jamaluddin, you made very early on, you got to expand production. You have got to have enough production of these products in enough places that we can guarantee global health security, which means equitable rollout and use of vaccines. Africa can't wait for other people to make the vaccines and give them to them. And Africa doesn't want to. Africa's got the skills, the brains, the talent, the companies that can make these products. It hasn't got access to the IP, or it hasn't got access to some of the other necessary ingredients because it's controlled by others. Africa has also got the regulatory frameworks. It's got the political backing, and there's financing that can be leveraged from this. There's no reason. Similarly, in parts of Latin America, parts of Asia, parts of the Middle East, we've got to expand production of these, because what the variants are also telling us, Prof, if I come back to the beginning, is we're in this for the long run. And we are using a sprint mentality, to tackle a long-run disease. So let's get smart. Let's optimize the tools we have equitably. We've got the enough of it to actually use them smart. Let's get our testing rates up. Let's be generous. Let's be the best humans we can be, because we can beat the virus, but only if we're the best people we can be, and we work together on this. The virus is taking advantage of every gap in our multilateralism that you asked me about at the very beginning of this, Prof. And thank you so much to Indonesia for pulling us together and talking about this, because this is such a great country that has done so many great things in this area and has got such a great attitude. And having you in the seat of the G20, as Yodi said, is so exciting for our ability to get out of this pandemic.
Thank you, Dr. Ewan. So we have to be the best human we can be. So That's very important. So now we go for the Q&A from the public. I have several questions here. I will read the question, and I do hope that the panelists, distinguished panelists, could reply to this question. The first one is from, let me see, from David Sharepukin from Georgia. I think this might go to, better, Minister Khairi, if you could kindly reply to this one. So David from Georgia mentioned that the pandemic in countries like Georgia seems to get both better and worse due to lack of cooperation from general population. So the question is mandated COVID vaccination possibly in the future? This should be mandatory for everybody. You already mentioned a little bit about carrot and stick. Minister Khairi, please.
Yeah, thank you for that interesting question. I think we have to always come back to the basic point, which many people have pointed out, which is that vaccination is part of an arsenal of tools that must be deployed in order to combat the pandemic. Relying on one tool alone is not going to be enough. So just as much as you deploy a very, very robust and wide immunization program, you need to continue to remind people of non-pharmaceutical interventions, which are so critical. And we've seen cases spike in countries with great vaccination programs because they've simply abandoned the non-pharmaceutical public health measures like wearing masks and avoiding crowded places. And I think because of the pandemic fatigue, people thought that once the vaccines were available, to hell with the mask. Let's just, throw caution to the wind. And I think we have to continue to stress to people that it's vaccines, it's your non-pharmaceutical interventions, it's your test, trace, isolate, and support, your FTTIS infrastructure, so that you can actually contain the spread. You can look after people who are having their home quarantine. You can trace people quickly with new technology or just with the traditional contact tracing. These are things that we knew from the start last year, but we must continue onwards as well. And I think with the new exciting antiviral therapies, these are things that we should look at seeing how it can be provided for through voluntary licensing regimes so that poorer countries have easier and cheaper access to them, add it to the arsenal of measures, and also to continue to strengthen healthcare facilities. My experience here in Malaysia, we're starting to see a lull in the cases, but we hope for the best, but we plan for every eventuality. So what we are doing now with this breathing space is to try to simulate what happens if there's a fourth wave of cases. Is there enough capacity in the hospitals? The greatest nightmare health minister has is, of course, hospital capacity, especially critical care capacity, ICU capacity. Once it breaches a certain point, then red flags are raised, and we need to have a heightened alert system, and we need to step down on certain social activities. So I think the question is a great one in a sense that, yes, mandatory vaccinations, if you can do that, and in Malaysia it's all but almost mandatory, but I think it comes with other measures which you still have to stick to, and countries which put aside public health, non-pharmaceutical interventions are really asking for trouble.
Thank you, Minister. So that is the Malaysian way to handle this one. So like you said, for vaccine availability, so it should be a basket portfolio, and for tackling this one, it should be also from different way of people, not only mandatory and other effort as well. If I now may go to Dr. Alakija, this is a question from Monica in Fiji. So she said that 1.1 of people living in low-income countries have received at least one dose of a vaccine, which is very low, as we already discussed. So the question is this an issue with doses being held in surplus and not being made available to people who need them? Secondly, she also asked, what is your thought, Dr. Alakija, on the difficulties faced in finding data around excess doses?
Thank you very much. Thank you very much, Prof. And Monica Bulla. This is a very close question to my heart because my second home is in Fiji. So I'm very happy to have a question from Fiji and very happy that Fiji is connected and is watching today. First of all, I think Dr. Aylward said it clearly. The issue has been with supply. It has been with hoarding. It has been with a lack of humanity, really, that we have in this moment lost our humanity. I think the Fiji experience, which of course I also know very well, and I spend a lot of time talking to people within our government over there about the vaccination strategy, speaks also to what we've just been talking about local and regional production. Fiji received at the very initial instance 12,000 doses. 12,000 doses of vaccine from COVAX. That was their first allocation. And when the exports were stopped in India because of their crisis, what happened was that regional solidarity, so it goes to your earlier question, Prof, about a regional response, regional solidarity kicked in. And because Australia had production facilities for AstraZeneca, because the tech had been shared, because they were able to manufacture in that region, the Asia Pacific region, Australia has been able to, and now New Zealand, has been able to give bilateral donations to Fiji of over 1 million vaccines, which quite frankly have saved that population. Fiji at one point had the greatest numbers and deaths per capita in the world. I mean, the numbers were small, so people did not really notice. But those of us who had friends and family members there who were literally dying every day could see that we have lost 3 people this week. We have lost 4 people this week. So Monica, to answer your question, the reasons for the lack of vaccination around the world, number one, the first part has not been that we don't have enough vaccines. It's been that we did not do what we should have done. We should have vaccinated the most vulnerable across the entire world first, health workers, the elderly, so that we protected lives, so that we provided a shield, some sort of a bulwark against this threat that we really don't fully understand. And then to your point about data, I completely agree, and it speaks to what Bruce said. I am desperate. I'm a data activist. I love data. I'm always sending texts to be it my daughter or assistant saying, work this out for me. I mean, I'm a medical doctor. I'm not a statistician, but we need more data because to understand what is going on in the world, we need data. You mentioned, Professor, the AY 4.2 variant at the moment. I am afraid because I'm afraid that we are not measuring, we do not have data on what is going on truly around the world. I'm afraid that we do not know what is going on in places in Africa where there are no non-pharmaceutical interventions being implemented, where there are no vaccines, and where people are literally just going about their day-to-day business, forgetting that we have this microbe which is outrunning us. This is a race between a virus, a variant, and a vaccine. I think there's a lot we still need to learn from what China is doing. I say this repeatedly because the way they clamp down whenever there's an outbreak, we need that data. So I speak to George today, and I say that we want to learn from you. I definitely want to learn from you. What is it that you're doing that we don't know and that we're not willing to accept and have dialogue on? This is a global pandemic. It is not China versus UK versus EU versus Nigeria. No, we are all in this together. We are all in this same boat. And currently the boat is sinking. We need data. We need global solidarity. And Monica, Bulla Vinaka to Fiji and Modemanda Vinaka.
Thank you, Dr. Alkija. Even though I do not understand that Fiji language you just mentioned, it must be a nice word for Monica.
So goodbye but hello. Thank
you so much. So now I would like to request, Professor Gao, if you could kindly cater this question from Katya Ivanov from Russia. So the question is, do you think that international organizations have succeeded in implementing vaccine multilateralism for the last 2 years? Even though we already discussed, but grateful if you get your view in this, whether international organization has succeeded in implementing vaccine multilateralism for the last 2 years. Professor Gao.
I think when you are talking something like that, first, look at the results. Second, have a close look at the fact. So the results and the facts. Do not tell us we are already doing a very good job for the multilateralism. So multilateralism is, in my opinion, so far, it's a slogan. It's only a slogan. It's nothing, almost, it's not really implemented. The idea is so good. The strategy is proposed, but we haven't seen any good results. I think this is why we should learn a lot from this pandemic. Otherwise, like I said, when I made comments about the vaccination, we must share the vaccine. If we don't share the vaccine, the virus will share the world. Not just the COVID-19 virus. We will have another virus. It will coming very, very soon. We must have another virus. It's coming very, very soon. So this is why, for the multilateralism, don't talk. Let's do something. Just put everything in practice. Let's implement some strategies, not slogan. So this is a very clear message I want to make. So we need political wills. We need public understanding, public involvement. We need wise authority making decision. It might be wise. Otherwise, the virus got their own wisdom. They will conquer us. We cannot conquer the virus. The virus will conquer the human beings. Thank you.
Thank you, Professor Gao. So we do really hope that the virus wisdom is not that good, so we can defeat that. Thank you, Professor Gao. So this is a question for Dr. Alwar. Actually, this is from Malaysia, from Iqbal from Malaysia. He said that other than donating COVAX to the countries with low vaccinated population, for instance, Africa, what are other smart alternatives that can be taken by producing nation, by government, or even by WHO to ensure this population, the one who receive only a small amount now, to ensure that this population get their vaccines equally and safely? Dr. Elmer.
Thank you very much. And Mr. KJ, if you don't mind me taking a question from your constituency, I'm very happy to do that. But it's a great question. What else can we do? First of all, use your voices. The power, politicians listen to the people. Use your voices and say, this is really important that we ensure the vaccines are rolled out equitably and that coverage rises in all places at the same time, because it's the right thing to do to get our lives back, get our livelihoods back, and for others to get their lives and livelihoods back. Use your voice, number one. And when you use your voice, then tell them the right thing to do. Number one, let COVAX contracts be served. Manufacturers are bound by contracts with high-income countries, with countries that have lots of doses, that they have to serve those before they can serve COVAX. That's what they're saying. So we need governments to come out and publicly say, you know what, COVAX can serve, manufacturers can serve those contracts. The second thing that we can do is say, look, we have enough of this product. Instead of giving it to us to give to COVAX, serve COVAX directly. That's what we call delivery swaps. There's been some really exciting delivery swaps, but you know what? The first delivery swap between, and this is for spaces in the queue to get vaccine, was between two industrialized countries, two high-income countries. One way over there in Asia's part of the world, and another in Europe. They swapped vaccines. They didn't swap it with Africa or with COVAX. They swapped it with each other. So let's be smart and use those swaps properly. The third thing you do is, if you're going to donate better. Stop earmarking the vaccines. Let COVAX send them wherever they have to go. Stop giving them with expiry dates that are less than 4 weeks. Stop giving them with other conditionalities. If you're going to be generous, be generous. So use your voice and say, prioritize COVAX contracts, let them buy the vaccines. Swap your place in the queue if necessary. If we're going to donate smart as we go forward. But the reality is, every single thing we're doing, we have to look and say, who is controlling the flow of the vaccine? Because we're doing a lot of things that we're pretending are generous, but what we're really doing is still controlling supply. We set up COVAX, and huge thank you, Prof, to Malaysia, Indonesia, China, Nigeria, all these great champions of COVAX. We set it up to ensure equitable distribution. And what's happening is people are putting conditionalities in there. So the last thing I want to make, Prof, you picked up an earlier point I made about, trying to be the best humans we can be. That's really hard without rules. And this is why the Director General of WHO is saying, look, we need a set of rules for the future. We need an instrument or a treaty, something that allows countries and politicians to be their best selves and to better share these products as we go forward. There's lots we can do.
Thank you, Dr. Ewald. So actually we have only 3 or 4 minutes time left. Just want to raise one question to all of these 4 distinguished panel, if you may wish to comment. Now there is a kind of question from general public. In one hand, there are countries that already vaccinate quite a number of their population, but still number of cases are rising quite remarkably. On the other hand, there are countries who are not vaccinating quite big number of their population, but they can still maintain the number of cases are low. Of course, all of the countries face the same problem of people are following these health protocols, etc. But what are the idea, or what are the scientific kind of explanation between this rising of cases on the countries that already vaccinated quite number of their population? If you may kindly give a comment, please. It's open for everybody. Maybe yes, please. Yes, start with WHO.
Maybe I can jump in. And I want to thank Minister KJ because he's already answered this question with exactly the right point. You cannot vaccinate your way out of this pandemic alone. You've got to be smarter than that. The virus will take advantage of any gap that it sees, and vaccines aren't perfect. So as you get your vaccine coverage up, you have got to maintain some degree of social distancing. You've got to use masks where it's appropriate, where people are crowding. You've got to continue to wash your hands. And I've been in countries recently where they have relatively high vaccination coverage, and that's it. I never saw a mask the whole time except for the one I was wearing. The virus is going to take advantage. We will get better vaccines as we get forward. We will get therapeutics. We will get better diagnostics. We will get all these things that will allow us to beat the virus completely. But in the meantime, we have to use what we have smart, and we're not. We can beat this virus, but we got to use our vaccines. We got to use our tests. We have to use our other tools. We have to use our brains as well. And we're not using our brains if we think we can have freedom days because the virus is still here and most of the world is still unvaccinated.
Thank you, Dr. Ewald. Mr. Kerry, you want to share something in this regard?
Yeah, I mean, I think I've touched on this earlier, and I think the whole complement of tools need to be used for us to, and the virus is not going to go anywhere soon. The transition to endemicity will take a long time. We're nowhere near that right now, and I think if countries feel that they can declare victory, I think they're sorely mistaken. But let me just end with this. I think the point about commitment to COVAX is something that needs political will. Malaysia had received bilateral offers of vaccine contributions, and actually told the countries who are donating, thank you very much, we will always remember this, but please, we have enough, give it to COVAX. And I've also rescheduled some of our delivery for this year because we've already we've done almost 100% of our adult population. So I said, look, instead of sending it to us, please fulfill other countries' requests. So I think countries really need to look at their own delivery schedules now. And if you don't need it, just tell the vaccine manufacturers, please send it to COVAX. And unfortunately, I just want to end with this. The whole issue with vaccines this year is a testament to the human condition. There's a scene in the movie of the Titanic where everyone's scrambling for lifeboats. And, the first class passengers got into lifeboats. There was space on the lifeboats, but people in third class were not allowed to come in. And this was a snapshot of the human condition of great injustice and immorality. And we just lived through this in real life over the last year. So I think it's not too late for us to say, look, let's address that, and we must address it now, as the Indonesian Foreign Minister so passionately put it just now.
Thank you, Minister Khairi. Professor Gao?
Yes, I want to readdress whatever Bruce just said. Try to smart use of our brain. You use work smart. At the moment, forget about the slogan. Let's do something smart. That's my message. Thank you.
Thank you, Professor Gao. Dr. Alakija?
Thank you very much. I have to echo what my fellow panelists have said. I have to say that this is one of the best panels that I have been on through this pandemic, because we really have gotten deeply into some issues. And when we talk about, we've heard about non-pharmaceutical interventions, we've heard about the fact that the vaccines versus virus and variants, this microbe is proving to be smarter than us. It is proving to have more emotional intelligence than us. I think it is not just smartness, it is emotional intelligence that is needed in this moment. And I agree with what Professor Gao says. We need to just do it. We need to just do it. There is too much talk. We need action. The world needs action. The Titanic is sinking. The lifeboats are sinking. We do not know what the evolution of this virus will be. We do not know what tomorrow is going to look like. But if we do not come together as one, regardless of our political, whatever geopolitical views and allegiances, we are not going to end this pandemic. So absolutely, I agree that we need to, for the countries where, one quick last statistic, for the countries where they're non-farming, basically there are no vaccines, what we're not counting also is excess deaths. We have in Africa, as of a couple of weeks ago, we are seeing an 800% increase in excess deaths that people are attributing to malaria, to typhoid, to something else. But because we have no diagnostics, they're not attributing to COVID. In the EU, they've seen a 60% increase in excess deaths at the same time. So what we're seeing here is who is going to accept death and who is going to not. Which lives are disposable and which lives are valuable. Which countries place and put value on certain lives. And all our lives are important. All our lives are valuable. And that is not a decision for politicians or global health leaders to make. It is only a decision for the Almighty who lives and who dies. And we have to together work as one towards ending this thing once and for all. Thank you so much. Lovely, lovely to join you all. Really, really appreciate the invitation.
Thank you so much, Dr. Alakija. So, distinguished colleagues, ladies and gentlemen, I think all of us agree that this is a very rich discussion. I do hope that it will, give a very important input for our fight for this pandemic COVID. If I may just raise three kind of, not really conclusion, but three remarks. Number one, we all know that vaccine is very important in our effort on tackling the COVID pandemic, but we realize uneven distribution and equality of vaccine globally right now. Number two, global public health need to be much stronger. If we read the independent panel report on COVID-19, it is mentioned regarding the global reset. So we might need a global public health reset. For us, global solidarity or global public health can do better. And my third point, I just quote from Minister of Foreign Affairs Indonesia's statement that now is the time for action. Thank you very much, Minister Khairi. Thank you very much, Professor Gao. Thank you very much, Dr. Alakija, and thank you very much, Dr. Ever. All the best to you. Thank you very much indeed.
Thank you.
See you all in Abuja next year.
Thank you for organizing.
Looking forward.
Thank you.
Thank you, Professor Aritama. As mentioned earlier, it is now time for the third Global Town Hall Quiz, open for all audiences worldwide. 2 winners for this session quiz will receive a cash prize of $100 each. Thank you to TempoScan for sponsoring this session, and allow me to read the game rules. Participants must follow our Twitter at FBCI Indo to join the quiz. The quiz question will be posted on Twitter once we begin. To answer, reply to the tweet using the hashtag GTH2021 at hashtag GTH2021 quiz. The question will be multiple choice. Your answer must either be A, B, C, or D. The answer format is your answer, space, hashtag GTH 2021, space, hashtag GTH 2021 quiz. The first two people who comment with the correct answer will be given the winners of the quiz. Winners will be announced on our Twitter page right away. Now, without further ado, the question is, how long has TempoScan been established in Indonesia? A, 50 years, B, 58 years, C, 64 years, D, 68 years. I will count down 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. The correct answer is D. TempoScan has been established in Indonesia for 68 years. The winner is announced on our Twitter page. So congratulations to the winners. Please claim your prizes by sending a DM to FPC Indo with your name and the screenshot of your tweet. Thank you for TempoScan for sponsoring this quiz, and see you during the 4th Global Town Hall Quiz, open for worldwide audiences. Coming up, we'll have another stand-up comedy session, which will begin after the break. See you soon.